And we are now live.
All right, good morning. This is the Senate Health and Welfare Committee meeting. It is February 14th and it's Valentine's Day. So I hope everyone's heart is healthy. Stay healthy. This morning, before we begin, I think to let you know, we do have now a list of the nominations, the confirmations that we are going to be looking at. So we'll go through that when we get a minute, as we keep saying, but we will do that. Thank you, Senator Weeks, for putting that together. Terrific.
So I distributed that.
Great. Yeah, thank you. So everyone can look at that, and then you can talk with Alex about accessing contact information, or if it's not there, and then if you need a resume, you can let them know. We're good. All right. This morning we are continuing our testimony on S37, an act relating to access to legally protected healthcare activity and regulation of healthcare providers. This morning we have with us Carly Thompson. And before we begin taking testimony, I'm going to have the committee go around and introduce themselves for everyone who is here and also on the Zoom. I think some of you know each other, so that's a good thing. So Senator Hardy, go ahead.
Hi, everyone. Hi, Carly. Hi, Anna. Hi, Crystal. I'm Ruth Hardy, Senator from Addison County.
I'm Terry Williams, Senator from Rutland County.
Jenny Lyons, Senator from Chittenden Southeast.
Good morning and happy Valentine's Day. Dave Weeks, Rutland County.
Good morning, Martine LaRoque-Dulick from Burlington. Happy Galentine's Day.
All right. So thank you all for being here, and we'll go through the list as they appear on the agenda and really welcome your testimony. So we'll begin with Carly Thompson. Why don't you introduce yourself for the record, let us know who you are, and then we'll hear your testimony on S37. And I'm going to ask, I haven't looked yet, did you submit written testimony? Yes, oh good, okay.
I have a PowerPoint.
Terrific. And Alex, can Carly share screen then?
Yes, she should be able to now.
Okay, I will try. Is it working?
Yes, it is.
Okay, great. Let's get the notes. Let's do the full slide. Why isn't it on full slide here? Shoot, sorry. Nope, that's not what I wanted to do. Well, you know what? We'll just get started so we're not wasting any time. Okay, everybody. So I had some computer troubles this morning. My Zoom on one computer crashed and the college computer doesn't have PowerPoint. So I'm going to be reading from my notes from one computer and sharing my screen from the other computer. But anyway, I'm Carly Thompson, and I'm an assistant professor of gender, sexuality, and feminist studies at Middlebury College. And before we get started, I just wanted to thank everybody on this committee for inviting me to be here today. I'm grateful for your time and also to be in conversation. For more than a decade, I've been conducting research around crisis pregnancy centers, which I'll refer to as CPCs from here on out. I have published articles on the topic in several academic journals, including Human Geography, Political Geography, and Signs, which is a top gender studies journal. I've also written about CPCs for media outlets and public-facing forums, including the New York Times, Ms. Magazine, and the Social Science Research Council's The Imminent Frame. So today I'll share with you a broad overview of what some of this research on crisis pregnancy centers says, briefly touching on a few different issues. And of course, there's a lot more to say than I could possibly fit into this allotted time. So I'll leave some time at the end for questions so that we can expand on whatever parts are most of interest to you. So in my brief remarks, I'm going to talk about the public health concerns that CPCs raise, their place in the anti-abortion movement, and the role that they're likely to continue to play in the post-Roe landscape. So first, a little bit of background information. What are crisis pregnancy centers? CPCs are religiously motivated anti-abortion nonprofit organizations that function as the backbone of the anti-abortion movement. They are also unregulated. Advocates' key goal is to prevent what they call abortion-minded women from obtaining abortions. Scholars have illustrated the many deceptive strategies that CPCs utilize to actualize their goal. So these are a few of them. They disguise their political and religious motivations, including through giving themselves neutral sounding names, such as the Women's Center, which is actually the name of the CPC in Middlebury, where I live, implying that they offer abortions when they do not, opening near abortion clinics or in former abortion clinics with the intention of confusing and thus hijacking those en route to clinics, and peddling false medical information. Scholars found, for example, that 80% of crisis pregnancy center websites that are listed in state-based resource directories for pregnant people include false medical information, including that abortion leads to breast cancer, infertility, and mental health issues, among other claims repeatedly proven false. We see these strategies play out in Vermont, including at the Middlebury CPC. Another tactic that CPCs use is to encourage clients to delay making appointments with healthcare providers in hopes that the delay will push clients to the point where it's much more difficult to obtain an abortion, or even in some states illegal. The health consequences of this misinformation can be devastating, both for those who ultimately end up seeking abortion, as well as those who carry their pregnancies to term. And the latter we hear far less about. So with that quick overview of what CPCs are and what they do in place, I want to discuss the place of CPCs in the anti-abortion movement. This figure is, believe it or not, the best representation of the best data that there is on the relationship of CPCs to abortion clinics over time. But considering, as you can see here, that it ends in 2007, when there were still twice as many abortion clinics as there are today, well, the picture is actually much worse than this figure suggests. Today, there are 2,600 CPCs and 700 abortion clinics in the US, numbers that were reversed in the mid-1980s. So as we can see here, this demonstrates the centrality of CPCs to anti-abortion activism and to the decimation of abortion clinics. More volunteers, volunteer hours, and resources go toward crisis pregnancy centers than all other forms of anti-abortion activism combined. Many people encounter CPCs on a regular basis, not through just going to CPCs, but also through their paid targeted advertisements for free pregnancy tests, billboards, posts on social media, increasingly their mobile vans and buses, and abstinence-only sexual health education classes, which they promote through high schools and even middle schools all over the country. The medical misinformation that CPCs spread through these approaches does not only impact the people who end up in CPCs, it has a broader social function, and that is to spread anti-abortion ideologies. CPCs frame abortion as traumatic, damaging, dangerous, and hurtful. They include statements on their websites and in their materials about post-abortion stress syndrome, a condition that is not medically recognized precisely because studies demonstrate that 95% of people who obtain abortions feel like it was the right decision for them. Put otherwise, the syndrome was made up by anti-abortion activists for political purposes, and CPCs have a stake in furthering that misinformation. Recently, CPCs, including the CPC in Middlebury, as the screenshot shows, have been adding to their websites information about what they call abortion pill reversal, which is unproven and also medically dangerous. ACOG, the American College of Obstetricians and Gynecologists, says that claims regarding abortion reversal treatment are not based on science and do not meet clinical standards. It is through this variety of commentary that CPCs do their most insidious work to spread anti-abortion ideology. They act like they care, in other words. Perhaps somewhat shockingly, considering the centrality of CPCs to the anti-abortion movement, no one had examined the geographic relationship of CPCs to abortion facilities, even though for a long time movement activists have been discussing how CPCs chase abortion clinics. So with my research assistants, I mapped every CPC and abortion facility in the US and analyzed their locations in terms of race and population density. And then once it became clear that Roe would be overturned, we reran our analyses, taking into account states where abortion was certain or likely to be banned. The results are these maps right here. So unfortunately, we don't have time to get into the data weeds here, so I'll just tell you in short a little bit about what these maps show. And basically, it demonstrates that people live a lot closer to CPCs than they do to abortion facilities. And the map on the right shows that this relationship is going to get worse or is getting worse. Okay, so furthermore, post-Roe, the number of people living closer to a CPC than an abortion facility almost doubled. The number of people living more than 2 hours from an abortion facility increased tenfold, and more than half of the people in the United States now live more than an hour away from an abortion facility. In 13 states, more than 99% of people live closer to a CPC than an abortion facility. And there are racial implications to these findings. Post-Roe, well, actually, this first slide, sorry, is about geography. So we found that post-Roe, people in large metropolitan areas living closer to a CPC than an abortion facility would rise to nearly 44%, up from 12%. In small metropolitan areas, it would rise to 68%. And in rural areas, which is obviously much of Vermont, it would rise to 88%. Disparities will also manifest along racial lines, and that's what these graphs show. The percentage of Black people and Latino people living closer to a CPC than an abortion facility has more than doubled, and more Native Americans than any other racial and ethnic group live closer to a CPC than an abortion facility. To be clear, the remaining people not captured here overwhelmingly do not live closer to an abortion facility than a CPC. They live equidistant to both. So put otherwise, less than 1% of people in the US live closer to an abortion clinic than a CPC. And this matters for many, many reasons, including that studies show that people are more likely to go to a CPC when it is nearby. And the same is, anyway, we'll leave it there. In short, CPCs and their strategies are ubiquitous. They are everywhere, and yet they are largely unregulated, also almost everywhere. But we don't actually need fancy maps or big data to make clear the dangers of CPCs. We just need to listen to the anti-abortion movement itself. Under the guise that they are medical facilities, they collect what clients often think is private medical information, even though CPCs are not required to comply with HIPAA or other patient privacy laws precisely because they are not medical facilities. That people can confuse CPCs with medical facilities reflects CPC strategies. Some CPC volunteers wear white lab coats. The aesthetics of CPC waiting rooms often mirror those of medical clinics. They deploy medical imagery on their websites and mobile vans. And perhaps most horrifying, CPCs increasingly offer free ultrasounds, or what they describe as free ultrasounds. Although these ultrasounds are meant to be non-diagnostic, that is, they are not meant to diagnose anything, although they don't make clear, CPCs don't make this clear to their clients. In addition to collecting data on the clients who come into their centers, CPCs collect data in a lot of other ways too, including through their online chat services, period trackers, and other smartphone apps that collect and share information about people's menstrual cycles. And geofencing allows them to send ads for CPCs to people who are inside reproductive health clinics in the moment, in real time. And they actually aren't even shy about these practices. A statement from Next Level, which is a data management software company developed by Heartbeat International, which is one of the 4 major conglomerates that link CPCs, reads, and this is a quote on the screen, "As big data revolutionizes industries around the globe, now is the time to do the same for life-affirming work of pregnancy health. As we pool together what we've learned separately, we can begin to wield game-changing predictive and prescriptive analytics that lead to stronger outcomes," which are, of course, fewer abortions. Perhaps even more worrisome, states and CPCs where abortion is illegal are set up to aid in state surveillance and potentially even increase and potentially even the incarceration of people who obtain abortions. In short, CPC should be a major concern to everyone who cares about reproductive justice. Sure, of course, that's obvious, but also to those who are concerned with public health and data privacy issues. And unfortunately, I realize I'm out of time, but I want to close by commenting really briefly on the proposed legislation as written. As I read it, the legislation would primarily prevent CPCs from falsely advertising about the services they provide. This is crucial, and I want to applaud the committee for putting together this legislation. And at the same time, I want to respectfully suggest that the legislation could, and in my mind, should go further. CPCs should be prevented from circulating false medical information both orally and in any of their written communications. Research makes clear that there are no links between abortion and breast cancer, suicide, depression, or ability to reproduce in the future. Major medical organizations, including the American Medical Association, have repeatedly made statements to this effect. And yet CPCs continue to make these claims, which are given credence because people believe that they are medical facilities. On this note, those medical professionals who are associated with CPCs should be legally required to follow the laws and ethics associated with their positions as healthcare professionals, even when at CPCs, precisely because their positions as medical professionals elevate the believability of their false claims. Lastly, in practice, I worry that attempts to ensure that CPCs only give out accurate information about the services they provide won't actually change much in terms of their current approaches. The Middlebury CPC's website, for instance, includes in much smaller print than its other claims that it provides, claiming that it provides abortion information, and at the very bottom of their webpage, the following disclaimer, and this is a quote: "We provide education on abortion and pregnancy options. We do not refer for or perform termination services," end quote. Every time CPCs use the word abortion in writing, they should be required to include parenthetically, "We do not provide abortions or referrals for them." This would clear up any confusion. What we know about CPCs is that they care more about their mission to prevent abortion than the health of the individuals who seek their services, than data privacy, and then public health. And it is for these reasons that the proposed regulations on CPCs should be pushed even farther than this legislation does. Thank you for your time and consideration.
Thank you. That was a lot in a short period of time. You did it. And you're a professor, so we get that. Unless there are questions about specific slides, we probably could let you take your slides down. And before you do that, you did mention the data company that is, can you give us the name of that company? I know you mentioned it.
Next Level, and they're a subsidiary or attached, I should say, to Heartbeat International.
Okay, thank you. All right. And then your slides are very helpful. Your written information added to it a great deal. If there's anything you can send us that would help explain some of the graphs, that would be useful.
Happy to.
Questions, Senator Hardy?
Thank you. Professor Thompson, thank you. Do you have data on the number of CPCs in Vermont and the sort of mapping that you've done on a national level, on the state level?
I can get that for you for sure. I could send that in with, in the next couple of days. Certainly. I know that there are more CPCs in Vermont than there are abortion providing facilities, and the numbers of CPCs are growing, and that is not true for the number of abortion clinics, precisely because the regulations make it a difficult industry to grow in, and CPCs are so unregulated that it's quite easy to just add a new one. And we're seeing that there's some CPCs in Vermont that have recently added mobile crisis pregnancy centers.
Okay, that would be great to have that Vermont level data.
Yeah, I'm happy to send it.
And do all the facilities, you mentioned the ultrasound machines, and that is particularly concerning to me because that seems to be the provision of medical care. And do you have data on who has those? And I'm not sure how we regulate that, but that is definitely a concern.
Yeah, well, one thing that could potentially happen is that one of the problems is that there aren't a lot of regulations around the provision of ultrasounds anyway, and like the kinds of licenses that you need to run an ultrasound machine. But I think that considering that they say that they're non-diagnostic, I think that the language they should really be required to use is that they're providing sonograms. They're providing images of a fetus. That's what they're providing. They're not providing an ultrasound. And I think that that's a really key distinction, because we don't necessarily think of an image as a medical procedure. We think of the ultrasound itself as the medical procedure. So that is one thing I would say. And I don't know how many of the CPCs off the top of my head in Vermont are using ultrasound machines, but I do know that the one in Middlebury got one within the last couple of years. And also they are partnered with another CPC, and they're sharing resources around ultrasound machines. So, or that was the case at some point. And it was precisely their decision to include an ultrasound machine that led one CPC to change its name from something like the Women's Center to something that included the word medical in the title of the CPC. So the thing is, they can name themselves whatever they want, and they don't have to, it doesn't have to be connected to whether or not they offer ultrasounds or offer sonogram imagery, but we increasingly see that their deployment of this tool is used as justification for their claims that they're becoming more medical.
Okay, thank
Okay,
you.
I'm gonna think we probably
Yeah,
should
yeah.
move on. And thank you for being available to us. We really appreciate it. And if we do have further questions, we may, we'll have Alex connect with you. That would
Sounds
be
good. Thank you so much. Thanks for your time.
I do have one ask of you, and that is, do you know where the funding comes from for these centers? And you don't have to respond, but it would be helpful to have a written response
Okay.
about.
You got it.
All right,
I'll send
terrific.
some additional information by email.
All right, good.
Thank you.
Dr. Venuto is with us, and I know that your schedule is probably extremely busy, so we welcome you and thank you for being here, and would love to hear your testimony. So introduce yourself for the record and we'll listen.
Thank you so much. I just want to acknowledge that I am coming out of surgery. So this is actually what I'm wearing today, and not, so I apologize for not being able to be with you. Good morning. My name is Dr. Anna Benvenuto. I'm a board certified OBGYN who's been practicing at Porter Medical Center in Middlebury for the past 10 years. I've also served as Porter's Chief Medical Officer for the last 4, and I testify today as a member of the Vermont Medical Society and a clinical leader within the University of Vermont Health Network. As long as I have practiced or served in a leadership position, I've remained committed to providing a full range of reproductive health care options to patients in our practice, including abortion. In a small community, our patients consistently express gratitude for the ability to receive the types of care that meets their needs in a compassionate and integrated way. While providing abortion care is valuable and necessary health care, it continues to unfortunately be contentious and politically charged. As an abortion provider, I'm cognizant of the potential risks that come with that decision. I've had to make specific choices about privacy in order to create some protections for my family, knowing that violent and threatening acts are not isolated to providers. I support S37 for the protections from violence and litigation directed at healthcare providers who are engaging in evidence-based medicine. I want to particularly express my concerns about the misinformation advanced in our community and others by the local so-called crisis pregnancy centers. For example, in my community, the name of my practice is Porter Women's Health. The local crisis pregnancy center recently rebranded as the Women's Center. This organization generates materials that are incredibly misleading. Many pregnant people in our community have felt deceived and confused by their interactions with the organization. They do not understand that it is not a medical facility and they are not receiving factual medical information. I have seen people in my clinic who have received ultrasounds that have been inaccurate or have reviewed their website seeking abortion services only to receive what they characterize as coercive anti-abortion counseling and inaccurate information such as reversing medication abortion for which there is no approved treatment. As a physician who believes in honoring patient choice and creating care environments that support individual and evidence-based decision-making, it is infuriating that this type of organization is allowed to continue to operate in a manner that is deceptive and provides inaccurate counseling about healthcare. Strengthening language that could result in the restriction or elimination of misleading practices that originate in crisis pregnancy centers is critically important at this time. I have been shocked by the way they've been able to generate and perpetuate untrue messages about the services they provide. I'm consistently shocked by the way they have chosen office sites and changed the name of their organization to more closely match the location and names of OBGYN practices. When their website was recently updated, there were new sections included specifically about abortion. And until you reach the very bottom, after they offer ultrasounds and visits for counseling, they mention they don't provide abortion. However, when you Google abortion services Middlebury, Vermont, they are the first option that comes up. Even savvy medical consumers have been misled by their website when seeking care, and I find it reprehensible and irresponsible that their misleading practices are allowed to continue. I am so grateful for our legislators who are working on behalf of patients across our state to both protect them from medical misinformation, but also to advocate for the health and safety of our healthcare providers. Thank you for your time and support of this work.
Thank you. Do you have your testimony in writing that you could send in to Alex?
Yes.
That would be helpful. And there's no need to apologize for your schedule. We're very understanding in this building and appreciate the work that you're doing. Thank you. Questions? Go ahead.
Thank you, Madam Chair. Thanks, Dr. Benvenuto, for being with us. I'm wondering if you could speak to, as a physician, the medical harm that could be done to a patient who might have a complicated pregnancy or some other issue, who goes to one of these clinics before seeing an actual medical provider.
Yeah, thank you, Senator Hardy. You know, a couple of things come to mind. The first is if someone is seeking a termination of pregnancy, receive inaccurate dating, information about how far along they are in their pregnancy, that could make a procedure either impossible for them or complicated. As one advances in pregnancy, procedures become more and more risky to the person who is carrying the pregnancy. The other thing is that there are people who we see who have, they're either on multiple medications or have specific health conditions that would be life-threatening for them, or medications that would cause harm to the developing pregnancy. And in those cases, termination of pregnancy or an abortion is the most appropriate medical care for either the developing fetus or the pregnant person. So delaying the initial care, early pregnancy care is critically important, whether you continue a pregnancy or you decide to end a pregnancy.
Thank you.
Okay, so thank you. That resonates. Any other questions for Dr. Benvenuto? I think I said it right. Okay. Any other questions? Okay, we're good. Thank you so much. We greatly appreciate your time and look forward to receiving your testimony in writing. It'd be great.
Thank you.
Okay, good. And we're going to move on to Crystal Kanoki, a student at the University of Vermont. Crystal, you're here. Alex, can you get her screen on?
She came off video.
There we go. All right, here you are, and you're still muted. Well, so introduce yourself for the record, and we would enjoy listening to your testimony.
Okay, hello everyone. My name is actually pronounced Christelle Tanoki. I am a junior at the University of Vermont. I guess a little about me and my extracurricular activities. I am the president of our new Public Health Advocacy Club, also known as FAC, along with the Minority Association for Pre-Medical Students. I also am the coach and founder of the Elite Dance team. I wanted to thank Professor Thompson and Dr. I do not want to butcher your name. I was listening intently to how it was pronounced, but Benvenuto, is that how you say your name? I hope. I wanted to thank you guys for your testimonies. And then, so I'm going to read mine. It's way more broad, and then talk a little bit about what my club was planning to do about the CPCs in Vermont, downtown specifically. Okay. So enacting preventative measures is the most important yet most absent measure we fail to take in healthcare in America. This bill gives the residents of the state of Vermont the liberty to protect their livelihood and future unplanned circumstances. This bill reinstates power back into their hands. It gives Vermonters more autonomy when it comes to their medical fate. According to the United Health Foundation, unintended pregnancy is either unwanted, occurring when no children are desired, or mistimed, occurring at a different time than desired. Delayed or lack of prenatal care among women with unintended pregnancies can pose health risks to mother and baby. Births resulting from unintended pregnancies are associated with adverse health outcomes for the mother and the baby, including low birth weight, shorter duration of breastfeeding, increased risk of postpartum depression and prenatal stress, along with physical and psychological abuse. Public insurance programs such as Medicaid pay for about 68% of unplanned births and 38% of planned births. In 2010, expenditures on unintended pregnancies by Medicaid and other public programs were estimated to be around $21 billion. The population most at risk of these outcomes are non-Hispanic Black women, who have a prevalence more than twice that of non-Hispanic white women. In addition, women with incomes below 200% of the federal poverty level, compared with women with higher incomes, women without a high school education compared with women with higher educational attainment, unmarried and cohabiting women who have a prevalence more than 4 times that of married women. Implementing a bill that will protect healthcare services is not only inclusive, but shows responsibility, compassion, and comprehension of these prevalent issues. Regarding the gender-affirming aspects of the bill, Vermont has the 7th highest rate of LGBTQ people in the nation, according to a survey analysis from the Williams Institute at the University of California, Los Angeles. It also has the highest rate of same-sex couples in the nation. At the University of Vermont, where I attend, our PRISM Center works to serve the diverse queer and trans communities at the University of Vermont. We support and empower lesbian, gay, bisexual, transgender, and queer students, as well as students whose identities fall in between or expand beyond those categories. And we work together to create a campus community where people of all sexual and gender identities can thrive. They need to have legislation behind them that supports that. The deprivation this community has faced when it comes to governmental support has been too severe. So let's just give this bill an opportunity to amend that. Thank you. And if there are any questions or comments, I can talk about what FAC wants to do to help the CPC centers.
Thank you. And if you have your testimony in writing, we can then post. Can you send it?
Yes, I will send that.
Terrific.
I will, yes.
That's terrific. Thank you for your testimony and for everything that you're doing. It's quite a lot. Yeah, quite a lot. And your Sue.
Yeah.
Questions for Christelle? It's Christelle.
Christelle, yes.
Okay.
If you have time.
Just ask a short one.
Christelle, thank you, and thanks for correcting the pronunciation of your name. I'm wondering,
Always.
2 things, and you can follow up in writing if we don't have time. What the students are planning in terms of action surrounding CPCs, and also slightly different topic, and this is maybe what you could reply in writing on, is whether or not that you feel like UVM has sufficient reproductive and gender affirming healthcare for students. This is another section of the bill, and I just was curious about that from the perspective of students. So if we have time for any response, or if you can respond in writing, that'd be great. Or to answer it.
Why don't we ask you to add a paragraph, if you don't mind, onto your written testimony in response to Senator
Okay.
Hart's question? Is that too much to ask?
No. Just her first question, I can just say in a sentence, as long as write a more in-depth paragraph, just because I am really excited for what we have planned. And and this was an idea of a previous student. I believe she might have already been graduated, or I think she already graduated, but her plan was to kind of storm these centers. And we want to do it more strategically, like very carefully write a plan of how we're going to do so, but kind of just drain them of their resources. So they're getting, wherever they're getting these funding from, like if people aren't using them, or if people are using them and they don't understand how it's being like used, we want to go with the knowledge that we have and ask those questions and use those resources and basically play their game, if that makes sense. We have a lot of students who are eager and willing to do so. So on one of the next few weeks, we're willing to just a group of us all go down there and ask all these questions and like take part in their services.
Thank you.
Mm-hmm.
That's very helpful.
And will you send us information about what UVM's services are and whether you feel they're sufficient for students? That would be great. Because that's
Yes.
a part of the bill.
Okay, yes, I will do so. Thank you.
Okay, thank you.
Of course, thank you
We're
so
going to
much.
move ahead to the Interstate Compact. There's a section in the bill that asks for a short report regarding the effect of the Interstate Medical Licensure Compact on physician and other physician practices. And we also have a nurse compact, which is not here, but we're hearing from OPR about that. So we've reached out and we have two folks here. Marshall Smith is the Executive Director of the Licensure Compact Commission. And then we have Rick Masters, who's the legal counsel. And I'm assuming that you two, I shouldn't do that, but are you two synchronizing your testimony?
Yes, I'll be providing, my name is Marshall Smith, and I'll be providing the testimony, and Rick and I will then be responding to any questions that you might have.
Thank you. Okay, so, and we don't have anything on our webpage from you yet, so whatever you can, please provide in writing so we have something to refer to.
I will certainly do that.
All right, so you can introduce yourself for the record, and we look forward to your testimony.
Thank you and good morning. I appreciate this opportunity to provide testimony on Senate Bill 37. My name is Marshall Smith, and I'm the Executive Director with the Interstate Medical Licensure Compact Commission, which is a mouthful, so we call ourselves the IMLCC. I'm joined by Rick Masters, who is our legal counsel. Senate Bill 37 does not amend or alter the statutory provisions of the Interstate Medical Licensure Compact Commission as it's established in the Vermont Medical Practice Act. The IMLCC maintains a neutral stance regarding each member state's ability to control and regulate the practice of medicine in their state. And the provisions of Senate Bill 37 are an effort to ensure that physicians who are issued a license to practice medicine, both MDs and DOs, are protected in their efforts to use their state of Vermont issued license. This is consistent with the purpose of the compact statute, specifically in the purpose section of section 1 of 6 Vermont's VSA chapter 26 subchapter 3A, and I hope I got that citation right, which states in section 1420A, the compact also adopts the prevailing standard for licensure and affirms that the practice of medicine occurs where the patient is located at the time of the physician-patient encounter. The IMLCC is ready to assist the Vermont Board of Medical Practice and the Vermont Office of Professional Regulation as they are requested to do and the requirements placed upon them by this act should it become law. I hope that my testimony is useful in your efforts to ensure that physicians in Vermont can practice medicine and that practice ensures the highest levels of public protection. Mr. Masters and I are happy to answer any questions that you might have.
Thank you. So at a very practical level, what you're saying is that if a DO or an MD has a license to practice medicine in the state of Vermont, they can do that, and that there's no long arm related to the compact that would preclude them from doing that. Then that we do get some nuanced questions about folks coming from out of state to be treated. And then we get nuanced questions about the telemedicine for Vermont residents who are outside of state. So can you speak to maybe some of those gray areas or complex areas?
Yes. So with regards to the practice of medicine or how the patient receives the care, it really is one of those issues that the longstanding tradition, and it's part of the statute that I quoted, a physician is required to be licensed where the patient is located when they're receiving care. So let's use an example of someone from another state that comes to Vermont to receive care. Since they're receiving care in Vermont, and they're physically located there and receiving that care there, they are then required to be licensed and be treated by a physician licensed in Vermont. Telemedicine becomes a much, it's a more nuanced issue. But again, it goes to the same basic principle. So someone who is being treated via telemedicine, that physician has to be licensed where that patient is located. So let's say I'm from Colorado and I'm calling a physician in Vermont to receive telemedicine treatment, and that physician, since I'm located in Colorado, would need to be licensed in Colorado to provide me with that treatment.
Is there any effect that the compact has on that telemedicine, practice of telemedicine with respect to licensure?
The practice of telemedicine is the practice of medicine, and the compact does not have any jurisdiction or authority over a state's ability to regulate the practice of medicine.
Okay, and then I'll ask one last question and let other folks do likewise. The question about the bill itself, the language that's in the bill, is this something that, from your perspective, we need to go further in studying the compact?
Obviously, I don't want to tell you your business, but it appears that the bill as it's written is actually will effectively accomplish what I believe as I'm reading the bill. So this is my opinion on your bill, and I don't intend to hopefully I'm not insulting or overstepping my bounds, but my understanding is that you're requiring that any actions for physicians be reported to the compact, and the compact work with your boards of medicine and board of osteopathic physicians to complete the reports and provide that information. And I don't believe that those provisions are anything extraordinary or difficult for us to be able to do. With regards to what I believe some of this, the intention is that if another state should take action against a physician also licensed in Vermont, there are provisions in the compact that would say that that would be reported to your board. Your board is then obligated to investigate that action. However, it retains complete control on the process that it would follow with regards to that. So I think what you're attempting to accomplish is accomplished by this bill.
I see Rick Masters is shaking his head yes. So is that an agreement with Michael's comments?
Yes, I agree with what Marshall has said. I've looked at the bill. I think it's consistent with the compact. And as all of you know, you want to avoid a conflict with the provisions of the compact, and neither of us believe that that happens. And as Marshall says, any physician from Vermont who is practicing in a state under the compact is obligated to follow that scope of practice. And if they are following it, they are protected. And if they are subsequently disciplined by a state wrongfully, that would violate the compact. And at some point, we might have to enforce that. But we think your bill is consistent with what the compact envisions, is for everyone to stay in their lane. And as long as they're practicing under the scope of practice where the patient is located at the time the practice occurs, and that includes telehealth, then the compact protects the physician-patient relationship as well as the physician's actions.
I probably have the same question.
Thank you, Madam Chair. So what about the instance where a physician is practicing in another state, they're licensed, and they are practicing in a state where abortion care or transgender care is not allowable or permitted, and they are sanctioned in some way in that state, and then they move to Vermont or practice in Vermont via telehealth or whatever, and they have this sanction from another state because that state has laws against abortion care, or how would that impact their ability to maintain their compact license and practice in Vermont?
Thank you. So that scenario, part of the compact's process is that we've created a high bar, bright light standard. A physician disciplined for any reason, and that means discipline that's reported to the National Practitioner Data Bank. That physician loses their eligibility to participate in the compact, meaning that they can't renew. So if they've already gotten licenses through the compact, they can't renew those licenses through the compact process. It also means that they can't apply and use the compact to obtain additional licenses. However, the one caveat to that is that license has been issued by the state as using the compact process. So let's just use some for examples. A physician who is licensed in, say, and I'll go back and use Colorado again. I'm licensed in Colorado and Vermont. Colorado takes disciplinary action against my license. My ability to renew my Vermont license through the compact is lost. However, that license is issued by the state of Vermont, and Vermont can then take action and convert that license over to the traditional process and renew their license. So there's a short way of saying what I was saying is there is no prohibition against a state continuing to have a physician licensed in their state with regards to that physician being disciplined. But that's up to each state board to make that determination. They can't use the compact and they can't use the compact process anymore. But that doesn't mean they can't retain that license, and that doesn't mean that that license can't be renewed, and it doesn't mean they can't get any more licenses. It's just they can't use our process to do that. Does that answer your question, ma'am?
Yes, it does. It does also calls into question whether or not the compact is something that is useful anymore to us if
Yeah,
for this type of care.
for certain states.
Right.
Well, I mean, just because there are so many states,
That's what,
there's a lot of states that are going to sanction or de-license physicians for providing what is medically appropriate care. And they are going to lose their license in that state for doing their job and providing good care. And the compact is going to uphold that. And that just seems wrong. And it seems wrong that we're part of that.
And I understand, but it again goes back to the compact's basic principle that it's up to each state to determine how the medicine is practiced in their state, and we uphold that state's ability to do that.
So we could get into the debate about what is healthcare, what is medical practice, and what should be included under it, which we are doing in this bill. but a broader conversation at the compact level with your member states might be fascinating.
It has been, yes.
Yeah, I'm sure it has been. And I encourage you to consider the breadth of need that is in our communities for this type of care, not simply abortion care, but also for gender affirming care for so many people, whether they're young or adult. So it's you have a challenge in front of you. So.
And ma'am, if you would allow me, so that our commissioners meet on an annual basis, and we met in November, and we actually changed our rules with it as it relates to this disciplinary situation. The commissioners are fully aware of the impacts. Commissioners from both sides of the debate amended our rules that actually reinforce the idea that it's up to each state to be able to determine what they're going to do in these matters. So a physician who gets disciplined for this, if your state statute reinforces or protects their right to be able to practice medicine, abortion care or gender affirming care, then your state under our rules has that authority, and it's supported completely by the compact. The unfortunate part is the provisions that we've written in, which were designed and written before this debate even was envisioned, are to protect the public, and that protection is that as an organization, we're not designed to monitor and evaluate physicians' ability to practice medicine. Once a disciplinary action is taking place, each state board is. That's where your expertise in those matters lie, and that's where we've allowed that decision to be retained.
Yes, I think that's been very clear in your testimony, and that's very helpful. What is unfortunate is that for all of us across the country, we don't have the breadth of definition that would come from the medical community about what is medical care, medical practice. So, and that, I guess I would challenge you to open up that discussion at some point. It's not an easy one, but we know that there are practitioners historically. We can go back hundreds of years and look at the practice of medicine that is inclusive. So anyway, thank you for your testimony. Are there any questions of clarification?
I just want to add one thing. You mentioned that the requirements of the compact were supposed to protect patient safety, and the irony in this case is that they are doing just the opposite when it comes to abortion care and gender affirming care. And I think that's incredibly problematic, and you really need to rethink the whole thing at this point. And we clearly need to rethink whether we want to be part of the compact anymore.
Well, anyway, that's a different question, but it's a good one. All right, so Marshall, did you want us to add anything, or Rick, did you want to add anything? You can hear the comments that we've made.
It's certainly possible for the states collectively to amend the compact if they decide to do that. No one anticipated when the compact was first drafted that the Supreme Court was going to abandon over 50 years of legal precedent in the abortion issue. So we are conscious of the problem. On the other hand, we advertise ourselves as a tool of federalism, which means people on both sides of the question want their version of reality to be enforced in their state, and it still allows physicians to practice on an interstate basis as long as they're following that scope of practice. But we were at the American Medical Association meeting out in Tucson a month or so ago, and they're certainly dealing with this issue as well. So we're not unaware, but we are trying to respect the sovereignty of each state up to the point that the law allows procedures to be practiced in one state and and not in another. So again, we agree with you. It's a dilemma. It's not impossible to change the compact, but it's more difficult because all the member states obviously have to agree.
Yeah, thank you. Thank you for your comments. Greatly appreciated.
Thank you.
Any other questions? Okay, we're good. And thank you for being available to share with us. This isn't, of course, not the end of it, and good luck with your work.
Thank you very much.
Same to you.
All right. We're right on time, which is unbelievable.
This is true.
So we have Jamie Feehan here. And so we're switching our thinking for a second. We're looking at the medical malpractice portion of the bill. So Jamie, want to come up, and this is the first time you've been here.
It is.
Welcome.
Thanks for the invitation.
Good to have you.
I am Jamie Feehan with Kramer Paper, Eggleston & Kramer. I got a kick out of the agenda because Alex called me an attorney, and it's challenging enough at times being a lobbyist. I don't need that albatross. You should go by association for me being with Kramer, but sorry to digress. I'm here this morning on behalf of the American Property Casualty Insurance Association. That's a national trade association of more than 1,000 P&C members that write all lines of business in Vermont. Medical malpractice is a form of specialty liability insurance, so that's why you find it on the P&C side, not through sort of the health insurance we ordinarily deal with here in this committee, P&Cs. Your colleagues down on the finance committee, but glad to be here this morning. I'm here to speak only to a narrow provision found in section 2 of S37, and I'm working off the bills introduced related to, of course, medical insurance. It begins on page 5, and amendments are found on page 6. Just a little.
Let's just get there.
Okay.
Well, I want to go to page 5 at the bottom, and then we're going to go over to 6.
Yeah, it's amending on page 5 in the middle line 9, section 4724. Which I'll get to in a minute, and the amendments are found at the top of page 6, beginning line 1, going through line 10.
Yeah, you have different page numbers than us, because you're looking at, so it's 4724, okay.
Unfair methods of competition or unfair or deceptive acts of practice.
47.
Right. And it's creating a new subdivision under there. Just a little bit of sort of context. As this committee likely knows, like health insurance, P&C insurance is highly regulated by the states. And in Vermont, the primary regulator is the Department of Financial Regulation. This is amending what's known as the Insurance Trade Practices Act, which is sort of says in general that entities, including insurers and others regulated by DFR, shall not engage in any trade practice which is determined to be an unfair method of competition or an unfair or deceptive act of practice in the business of insurance. And then the Insurance Trade Practices Act then enumerates, I think it's, I don't have it in front of it, maybe 25 or so different acts or practices that have been set over the years. And you'll see on page 5 that back at the beginning, this not being amended, already under the 7th enumerated trade practice is unfair discrimination, arbitrary underwriting action. So this is sort of already in place. Insurers cannot discriminate based on within the same class of insurance, or they run afoul of state law and the regulatory powers of DFR. You don't see the other sort of other subdivisions under number 7 unfair, but the legislature felt over the years that they should further define underneath there what would fall in. So this is adding a new provision related to what you're talking about here in S37. APCIA understands the intent of section 2 and this amendment to prevent a med mal insurer to arbitrarily adjust risk classification and premium charge to healthcare providers because they happen to perform legally protected healthcare services. We're seeing similar shield type laws, including med mal provisions, service in other states, as I'm sure you're hearing from others. However, APCI also interprets the language beginning on line 1, again, sorry, my page 6, line 1, that says, and I'll just read it since we're not all working on the same. Discriminating against a healthcare provider as defined by blah, blah, or adjusting or otherwise calculating the healthcare provider's risk classification or premium charges. So we kind of view that as sort of a blanket prohibition on considering other underwriting factors that go into establishing a premium. Those might be, for example, well, in general, med mal is significantly based on the specialty, of course. It's based on the amount of premium, amount of coverage being sought. It's based on sort of the size of the practice, the staff, the standards of care in place at the office, the risk management policies in place at the office. And so we interpret this language to prohibit us from being able to do that, to help set the premium. And it should also be noted that through that underwriting process, each of these factors can either credit or debit the policy based upon that insurance practices employed and other factors that I mentioned. So if it's not the intent, and it is the intent to continue to permit those other underwriting factors to be included in setting premiums, I suggested at least a simple amendment that would add the word solely after charges. So in other words, it would read, or adjusting or otherwise calculating healthcare providers' risk classification or premium charges solely on the basis that, and then you get into the gist of what this bill is intending to address. And that's it. With that, I'm happy to take any questions.
That's it?
That's it.
Okay, that was, I won't use that word, but it was not complex.
Correct. Wasn't intended to be.
No, it's good. All right, well, thank you. I did meet with Jen and Ameren yesterday, and they did indicate that you had mentioned that.
I think you've got it posted.
Yes.
You've got it posted on our today as well. And we'll follow up if there's any further questions.
Questions? Terrific.
Thanks for the
Thank you for being
Appreciate
here.
it.
Actually, I am, I'm
Okay.
sorry, I'm thinking this through. Thanks, Jamie. Solely on the basis that the healthcare, if we add solely, then wouldn't you be able to in part be able to set their premiums on the fact that they're providing legally protected healthcare that's unlawful in another state?
We suggest this solely for a couple of reasons. One, I mean, we are seeing it service, for example, in Maine, a village filed that had this sort of solely or sole.
Yeah.
And we're seeing it in others as well. We kind of look at solely as a way to sort of freeze in time the current practices, because we would imagine that if someone were to all of a sudden shift their underwriting practices, and, new premiums that we're money, the providers will be the first line, hey, what's going on here? And either contact their insurer or DFR. Number two, those rate increases have to be reviewed by the department. And so the department can see any sort of aberration as well. And so I think, when I say freeze in time, if you start to see activity that otherwise wouldn't happen, that should be.
I guess by adding the word solely, it says to me that you would be able to take all of these things into consideration in addition to other things. You couldn't take them into consideration alone, but you could take them into consideration among other things that you use. And so, that's why I hear what you're saying, but I also am concerned that, when you and I are gone, somebody else will interpret this as something of, hey, we can say that, oh, this person provides abortion care that's illegal in another state. And they practice in, I don't know what other factors at the moment, but and then it can be one of the factors that's used to increase their med mal rates. I love that med mal.
That's a very good point. It's a good point, and you could interpret it that way. So
It's certainly not the intent. I mean,
I
there's.
knew it wasn't
there-
that word. I knew it wasn't that word.
It's not intended to, provide a backdoor.
Yeah, I understand that it's not intended, but I feel like we need to come up with a different way of getting at that.
The advantage of solely was it's simplistic, but there could be a way to say, and I'm happy to work with Ledge Council, for purposes of this subdivision, adjusting rates or whatever shall not include, and then sort of address the underwriting factors.
Yeah.
That are unrelated to these protected healthcare services.
Let me ask this question because I think Senator Hardy brings up a good point about out of state, and remind us how medical malpractice rates are established in this state. Do we use the risk associated with what goes on in other states, or are we inclusive of our
I don't want to
practitioners?
get over my skis on some of these
Okay.
things because it is sort of a specialty, but I don't believe, I believe it's, related to the insurer's application, lawsuits, because again, the factors that I mentioned, it's not necessarily factors outside of the state-based
That would be a good
entities
thing.
that are seeking insurance.
Okay, but if you have one person.
Right.
I know. Okay, so that's a point that we're going, fortunately, our ledge counsel has got our backs, as usual, behind us.
Like literally.
Literally, that's what I was thinking. So, and we work together.
Yeah, certainly, because it
Yeah.
sounds like that's not the intent to stop that from
Yeah.
happening. So yeah,
Yeah.
whatever makes you guys comfortable, happy to
Good.
do that.
We'll get that.
Great, thank you.
Okay. That's why I didn't use that word.
You never use the word simple in legislative context.
Welcome.
Ready for me next?
Cindy, thank you for being here.
Thanks for giving me.
You know what, I just realized that you haven't been here this year.
I haven't, no.
So,
Good thing you haven't needed the emphasis yet.
no, we haven't, no. We always need an emphasis. Why don't we do this? Why don't we introduce ourselves for you, so you know who we are?
Sure.
And then I'll start. Ginny Lyons from Chittenden Southeast. And
Dave Weeks, Welcome County.
I'm Martine North, you look from Burlington.
Ruth Hardy from the Addison District.
Terry Williams from Welcome County.
I'm Cindy Brzezzi. I am the Executive Director and Clinical Ethicist at the Vermont Ethics Network. And I also work part-time as a clinical ethicist at UPM Medical Center.
so we've been looking at S37 and that section on information. It's challenging. If you can speak to any part or all of the bill.
Sure. Oh,
Can you direct us to the
Oh, yeah.
section just?
What page is that? Toward the end.
all right, let's do my bag.
I have it.
It relates to sort of the testimony you heard this morning regarding pregnancy service centers.
Oh, yes, let's start with that.
And the sharing of the information that's being distributed. At least that's what
Yes.
the request was for. So as you heard this morning, and I'm aware that there's this growing concern, not just here, but across the country, around the advertising practices of these particular pregnancy service centers. And as I think those who testified earlier this morning articulated better than I could, it really centers around the use of misleading advertisements that pretty much induce women to come to the centers for care. And then the information that gets disseminated about abortion is largely inaccurate and it's inconsistent with evidence-based clinical medicine. And I think the providers that spoke this morning really drove that point home. Obviously, there are First Amendment considerations, that you guys as policymakers are weighing as you're trying to figure out how to regulate these types of centers. But my purpose today is really not to focus on that piece as much as to speak more broadly to the ethical implications that deception and misinformation has as it relates to healthcare and medical decision-making. So as a clinical ethicist, that's pretty much the work that I do, right? Is looking at these kinds of situations through that bioethics lens. I think when we're thinking about this, for me, it's important to sort of have some definitions. What is lying? What is deception? What does that actually mean? And I think, for me, lying are statements made by an individual who knows they're false or believes them to be false, and they're using them deliberately to mislead the person that they're speaking to. That's what lying is, right? Telling somebody something that's untrue. Deception is more broad than lying. it includes statements and actions that are intended to mislead the listener, whether or not they're literally true. And I think there are techniques that individuals and organizations use to deceive people. It could be using a lot of technical medical jargon that people don't understand, or making ambiguous statements, or using misleading or incomplete statistics, not answering questions directly, or omitting important qualifying or contextual information that's necessary to really understand what we're talking about. And misrepresentation is really unintentional as well as intentional statements that may or may not be true. So unintentional misrepresentations occur a lot of times due to inexperience, lack of knowledge or training. People don't actually even realize that they're saying something that's untrue, or they have poor communication skills and they're just unable to share the information in a way that other people can understand. So these are all the sort of layers of ways that people can knowingly and perhaps unknowingly mislead someone. So in general, there are really strong ethical objections to lying, deceiving, and misrepresenting things. I think this is even more true in the medical decision-making context, given that there's huge importance that we place in society on patient autonomy, on informed consent, and there's a necessity for trust between clinicians and patients when they're delivering healthcare. And these are the virtues that we bestow upon trained medical professionals. We expect them to be trustworthy, to be honest, to respect confidentiality and privacy, to be accountable for the information that they're delivering and the decisions. And I think more importantly, that they're responsible to promote what's in a patient's interests, not what's in their own self-interest. And this is what society expects of anyone who is professing to be a healthcare professional and delivering those kinds of services. And so, I want to talk a little bit about truth telling, because this comes up so much in my work. It is a near absolute in medical ethics that you tell the truth. There was a time long ago where it was considered permissible to deceive people if we thought that the information we were sharing was going to be too traumatic, and we call that therapeutic privilege, and it's very, very seldom used any longer. We recognize that people need to have the truth in order to make informed decisions. It's really how trained health professionals demonstrate that they respect patients, how they foster trust, how they promote self-determination and cultivate an environment where best practice and shared decision-making can really flourish. And that is the gold standard of medical decision-making, shared, where clinicians are the experts when it comes to the medical facts and patients are the experts when it comes to their goals and values. And together they come to a decision about what makes sense. That's what we're striving for. Without veracity in information and communication, it's really difficult for individuals to make informed and voluntary choices. And that's essential if we're going to fulfill our autonomy-based obligations to these individuals. So advertising strategies and tactics and educational information about options that are not transparent, that use misleading or ambiguous language, that misrepresent the services that are being provided, or provide factually inaccurate information, it's a form of manipulation. And it disrespects patients, it undermines trust, it broadens health disparities, as you already heard about, and it can result in actual patient harm. And that is not ethically defensible from my view as a clinical ethicist. The other aspect of this that is worrisome to me as an ethicist is sort of the professional responsibility and scope piece. Medical professionals are obligated ethically, legally, to do good for their patients. They have to provide comprehensive, accurate, evidence-based clinical information. And they're also equally obligated to avoid disproportionate burdens or harms. So we know that we harm people in medicine all the time. We cut them open, we perform surgeries, but we do that knowing that the trade-off is wellness, restoration of health. We're doing it for beneficial purposes. If we misrepresent the services or provide inaccurate information about abortion and its risks, then we may introduce disproportionate burdens and harms that lead to delayed opportunity, as I think you heard about earlier, for timely intervention and resulting in risks, I think, to women's health and also undermining their sense of well-being. These types of violations of beneficence and non-maleficence, those core principles in ethics, it's not ethically defensible to go in that direction. Healthcare providers are also obligated to engage with patients in a morally neutral manner. This is something that, is sometimes difficult to do. They need to check their own biases. And we're learning more about how we need to do better at that. They need to be judgment-free in the information that they're providing. And they're responsible to prioritize the primacy of the patient's interests over their own. And I would consider myself a relatively literate healthcare consumer. I found the websites that I perused in preparation for my testimony today very confusing, and it was actually unclear to me if the centers operating in Vermont are actually medical clinics with trained medical professionals, or if they're non-medical religious centers that are providing faith-based perspectives on pregnancy and abortion through the use of lay volunteers. I couldn't tell from looking at their websites, even when they describe who they are, what their training and expertise is. And I am knowledgeable when it comes to healthcare. So I can only imagine how confusing it might be for a vulnerable person who's stressed out about a potentially unplanned pregnancy to try to sort of navigate what it is they're stepping into. So the other piece of this is informing and counseling patients about risks and benefits and alternatives and medical procedures. That is the core of informed consent. In this state, the responsibility for obtaining informed consent rests squarely within the scope of practice of physicians, advanced practice nurses, and physician's assistants. It's ethically problematic, if not completely impermissible, for individuals with limited or no medical knowledge to engage in clinical discussions that's beyond their scope of expertise. I mean, doing so to me is sort of akin to practicing medicine without a license. And it represents a safety issue. It puts the health and welfare of women at risk, and it erodes public trust in the medical profession overall. So there was a quote on the AMA, the American Journal of Ethics, American Medical Association's Journal of Ethics, that said honest information about the perspectives from which they, pregnancy service centers, dispense advice and support, in addition to forthright acknowledgement of their limitations, is essential for these centers to provide an ethical service to women. And right now, based on what I've heard and what I'm seeing myself, it's highly concerning that the information that's being provided and disseminated right now. So as an ethicist and at the Vermont Ethics Network, we support the inclusion of language in S37 that would curtail this type of deceptive and inaccurate information pertaining to these services.
Thank you. Do you have this in writing? Do you have something?
I submitted all of it.
Oh, good. Okay, it's not up yet, so we'll get it, but it is so rich that it's really great. Thank you. And as you read through that section, I think starts on page 10. As you read through that section, is there language, are there definitions or language that we can add that would enhance and reinforce the ethical argument for inclusion?
I'll take a look at it through that lens. I think the language that you have accomplishes the goal that you're trying to accomplish, and whether or not you feel it needs to be bolstered with more sort of ethically framed language, I can take a look at it and get back to you via email with any suggestions or recommendations if you like.
Yeah, that'd be good. And if you have some, great. And but if it accomplishes what we want it to accomplish from your perspective, that's what we need to hear. Good. Senator Harvey, and then Senator Gulick, and then Senator Weeks. We'll go right around the table. Sorry.
Thank you, Madam Chair. Thank you, Cindy. That was excellent testimony. I really appreciate it. I'm particularly interested in the comments you made about patient harm and that it's potentially dangerous to patients to be deceived. And this was sort of my question. I don't know if you heard the testimony earlier to Dr. Benvenuto. Is the potential for patient harm if they get misinformation. And aside from, or in addition to the language that's in the bill, I'm trying trying to figure out ways that we can bolster sort of oversight of these clinics, and perhaps through some sort of regulation, some sort of licensure or certification process or something that they have to meet standards. And there are medical providers who are associated or claim to be associated, or the clinics claim that they are associated with them, and trying to get at it through the regulation of healthcare providers. And I know this isn't exactly your area, but if you have ideas for that, and sort of better regulation beyond the speech issue and the advertising issue,
Right.
that would be helpful too.
Yeah, I can think about it. I just, those are more sort of legal regulatory issues that I don't sort of spend my time as much in that lane as a clinical ethicist. I mean, I think it's important to think about harm, not just in the context of physical harm, which I think, as Dr. Benvenuto spoke about this morning, delaying access. It's about the harm that you create to someone's sense of well-being, right? I mean, it goes beyond just, we have obligations not just to the physical piece, but to the psychosocial pieces of who people are. And I think that's the piece that is most concerning to me as well, is that delaying someone's access could result in them needing a more invasive type of procedure, which puts them at more risk, and there's potential for harm. I mean, they talked about those things. Those are clinical risks that a physician would go through with an individual. But the element about what that does, that undermines, these are people that we want to have connected to our healthcare system. It's not people we want to feel like they can't trust the clinical people that they go to. So those are the other elements. I'll have to think about if there's ways in which, I don't know how you regulate that. And part of that is professional code. Yeah. These are professional codes of ethics, and trained clinicians are obligated to practice within their scope and to follow their codes of ethics. They're beholden to these types of expectations, and they're accountable because we regulate them, they're licensed, they have to get ongoing continual education. I mean, these are largely, from what I understand, completely unlicensed, and it's not clear to me who staffs them. Yeah. Who the people are that are actually doing the counseling and what level of training they have. I couldn't figure that out when I was looking at these websites.
And so when you start to dive into it, then you ask the question, maybe we should be looking at just that piece as well, and how to develop some regulatory framework. But that's another question. Forget this.
You have other people in the room that can probably speak to that.
Yeah, right. I can see they're all excited about it. Yeah. Senator Goulart.
I just want to say thank you very much for speaking to us today. I have my own personal experience with the CPC back in the 80s. I'm sure it was the early days of the CPCs. There was one right off of the UVM campus on Colchester Ave. And yeah, you do.
I remember it, yeah.
Apparently, Christelle made it sound like there's one downtown now, but at the time it was almost on the UVM campus. So I made the mistake of thinking it was a legitimate healthcare facility because it was so close to where all of us students were. But I was fortunate because I wasn't yet in any kind of crisis mode. So I was able to go in with a clear head. I immediately felt like I was walking into a trap. Everything from the artistic photos of fetuses on the walls to the literature that I picked up that was very one-sided and very biased. I just immediately was on my guard, and fortunately I was able to kind of back my way out of there, even though the woman who was working there at the time was giving me a very, very hard sell. But when you started talking about sort of a psychosocial harm, it just really hit home with me, because there was a real sense of guilt and shame that was being promulgated at that location, at that facility. And again, I'm just really thankful that for whatever reason, I saw through it very quickly, and I did feel a lot of sympathy for young women who weren't in the state that I was in, and I could understand how easily manipulated they could have been. And this was before, you know, websites or anything. So it was literally, you just walked in. So anyway, thank you. And this is really
Thank you for
important.
sharing that.
Yeah.
Thanks for sharing that story. I'm sorry you had that experience, but I'm glad you were able to extricate yourself.
Thanks.
Yeah, young people are particularly vulnerable.
Exactly.
Senator Weeks.
Thank you, Cindy.
You're welcome.
Your testimony is really quite compelling. I appreciate it. I have a question though. Having survived the campaign process, which includes websites and advertising and such, where we all grapple with how much or how little we disclose about one topic or another, we kind of choose. So back to your point about legitimate medical facilities versus CPC's market advertising. I'm just wondering if I understand what you're saying about CPCs and what they are or not putting onto the websites. I'm just curious if you took the same litmus test and ran that against smaller medical facilities advertising, if it was clearer, you know, if there's kind of like if there's any way to develop standards about what is legitimate and what's not legitimate, you know, so that we don't fall in the trap of a legitimate medical facility still not being, it's not clear, you know, if they're certified, licensed, et cetera. You know, I'm just wondering if in your research you focused on CPCs and found, okay, there's a problem there, or if you focus on CPCs and then also focus on legitimate facilities to see, okay, there's a very clear distinction between the two. I'm just wondering if you went down that path.
Yeah, I didn't go down that path to look at them. I mean, I think if you're a regulated healthcare facility, you are subject to all of the regulations that the state imposes on being a healthcare facility. My understanding is these are not-for-profit organizations that are not subject to any licensure or regulation. So they're pretty much free to advertise the way they wish. I do think this bill and this particular subject matter reminds me of the work that this committee did a couple of years ago on stem cell clinics.
Oh, yes.
Where we had a
Yes,
discussion about
very
similar types of advertising practices.
Yeah.
Where misinformation was being conveyed to consumers about the benefits of stem cell therapy, calling it stem cell therapy. And there was a lot of education that we did, this committee did, and then we did outside in the community with healthcare providers to sort of help people understand those therapies. And I believe this committee also moved forward with language in a bill that would regulate what needed to be disclosed so that it was clear to consumers what they were getting into when they entered one of these facilities. So I think there is some track record that you have in terms of trying to help people in the community navigate some of these types of misinformation campaigns that are just sending people down paths that they hadn't intended because they came in under a false sense of what they were actually being offered. So there is some historical, and pretty recent. You just did that in the last 2
We
years.
just did that last year.
Yeah.
Was it last year?
I think it was 2 years ago. I lost a little time because of COVID.
It was Zoom. Then I went to 3 national meetings to talk about the bill to influence other states. So it was well received by the medical professional.
And the proliferation of stem cell clinics is rather huge across the country. And this
Yes.
sounds from the testimony I heard earlier this morning, like there's something similar happening here. So there may be some parallels to draw from the work that you did previously that would be useful in this context as well.
Any other questions? Senator Simon? No
Thank you
questions?
for your
Okay.
question.
All right.
You're welcome.
So yes, any ideas that you have to improve the language would be helpful. And if you think it's not, that's also helpful. No, don't mind that. But we really appreciate your insight, and your testimony is so compelling and so rich, and always is, and we really greatly appreciate it.
Well, thanks for having me. Appreciate the opportunity, and thanks for taking this issue up.
Yes, thank you. Okay. So I see that our next witness is here and we're a little early, so I will ask David, if you don't mind, come up and we'll hear your testimony, and then we may finish a little bit earlier, but and then we'll go offline, and I do want to talk about some process stuff.
Cindy is maybe the toughest person to follow, but I'll try.
I'm sure it's going to be.
And I apologize, I am having a slight allergic reaction.
Oh, no, it wasn't the Valentine's.
I think it's the discussion of deceptive practices.
Okay, deception, do it every time.
See, what are the reasons?
That's what I'm saying, I gave him one of those.
So good morning, my name is David Englander. I'm the Senior Policy and Legal Advisor to the Commissioner of Health. I think I haven't testified before you in person this session. I have appeared via Zoom.
Been on the screen, but it's good to see you.
It's nice to be here in person, good to see everybody. I did testify very briefly last week on this bill. I don't have a lot to add. The department is assessing what it would take to collect the information that's required by pieces of the bill. I should start by, let me step back and start by saying, reiterating the department supports the intentions of this bill very clearly. There is a lot of that's being requested of the department. There's a question of what we have and what we could get access to and what the implications from that are. I'll give you, for instance. The Department of Health does collect information related to surgical abortions. We have those raw numbers, and they are published. They are published in an annual bulletin, but those numbers are statewide. We would be cautious, and I would think that folks in this room would be cautious about providing precise information as to the location of providers. We do get requests asking for the names and locations of providers, and we deny those requests if they're public records requests to the extent that we are able under the law. The Department of Health does not have information relative to non-surgical abortions that is prescribed. It is sometimes done by telehealth. I think we could talk about the relative wisdom of whether it makes sense for us to try and collect that information. I think that's a policy decision for this body, but I think from the department's perspective, we would want to be cautious about that. The chair, you and I spoke with legislative counsel. I think we have some ideas about how maybe we could work together to find some language where we could find ways for the department to assist, but also to looking at the quality of care questions, maybe looking at entities that do that work as part of their everyday, as opposed to what the department does.
Yes, and thank you for that. So we did have a very fruitful conversation this morning with Jen Carvey, and so I think the input from the Department of Health will help to inform the bill, improve it, and add value. So we'll see what comes out. And we'll look at comparative language when we do the markup of the bill.
Thank you, Madam Chair. And that's great. Are you specifically talking about section 9 of the bill, or that's the report on access to reproductive health and gender affirming healthcare services?
So there's a couple sections. So yes, I think section 14.
The higher ed piece.
The higher ed piece, yes.
And the
Okay.
Patient disclosure.
Yeah, so it's great that you are working with Jen and the chair on language that might work. The intention is not to have like specific information about where people get abortions or transgender care. It's really of, where are there gaps in medical coverage more broadly and generically.
Yeah, that's what we did talk about that.
Yeah, okay.
Yeah.
So
But once we collect that information, we have that information, and therefore it can be public. I
see. I get it. Okay, yeah, because that was, yeah.
That's why I'm saying, that's what I'm saying, the board
Yeah.
understands the intention.
Okay.
And I think that we can find a way to meet our collective goals.
Okay, excellent. And I mean, especially in conjunction with the piece about higher education, with the institutions that are in more rural parts of the state, whether people that, that age group in particular, but all Vermonters have access. So, yeah, I guess I just
look forward to seeing the proposed language before that. Yeah.
That way. Any other questions for David Englander of the Department of Health? Thank you.
My pleasure.
Yeah, and thank you for helping out with
Of
this.
course, yeah.
We're getting closer and closer, and we'll see how close we can get. All right, so Alex, I think that probably does it for our committee. We're going to make a wrap on our business meeting, and I just would like to talk briefly with the committee about process.
Are you ready to go offline?
Yes, please.